In order to impact healthcare, it's really going to take a collaborative impact and get out of silos.
EMS is the epicenter of patient navigation for all of healthcare. We're doing so many things in these other spaces.
Tell me how you got South Carolina to fund $1 million in the state budget when most are cutting their state budgets. Tell me how you did that.
And we didn't just bring a problem to them, we brought them a problem and we brought them a solution. One thing that we can say for certain is that it's not faster ambulances. That's not what's going to fix our problems.
Well, welcome to another episode of the Leadership Lab. Ecstatic that you have joined us, and I'm just really happy that one of my great friends is here with me on the couch here in Austin, Texas, Henry Lewis from the South Carolina EMS Association, but more importantly, from where my roots are. And I grew up in North Carolina, and my family lives in South Carolina now. So South Carolina holds a special place in my heart. And so ecstatic that I'm able to be live in the studio. Well, not really live, but in the studio with Henry Lewis from South Carolina. So Henry, welcome.
Thank you so much for having me. It's a pleasure to be here.
Absolutely. And so we're going to talk all things EMS today. So if you're listening into this and maybe you're not from the EMS industry, but we're going to give you a background into the EMS industry. So however you're joining us and the impact that EMS can make on healthcare in the communities. So Henry, I'm going to just stop here and just introduce yourself to who you are. Some of us know who you are, some of us do not. So I want you to take us back to how you got started in EMS. And then I've got a lot of questions for you, as you probably know, and we'll kind of work through this process. We do have an outline, folks, but more than likely, him and I will go off script just a bit. But give us a little bit about who you are.
Thank you so much, and couldn't agree more. I don't know why we would make an agenda when you and I talk. Started my career in South Carolina, small rural volunteer fire department, and quickly transitioned over to the EMS side in around 1999, so dating myself just a little bit. But from there, I worked rural EMS, went to our state EMS office, did some hospital-based EMS work, and then large EMS systems. In April of 2021, I became the first full-time executive director for the South Carolina EMS Association and really focused most all of my EMS efforts into that state-level organizational structure and how these local solutions to local problems can really move the needle and make a big impact.
And I'll tell you this one thing about when I met you for the first time, and it's been several years now. You can probably recall it better than I can, but the one thing that impressed me the most about you was your collaborative effort. And I think healthcare needs more collaboration. And actually you're in town because we did an event yesterday and we had payers in the room, providers in the room, legislators in the room. And really, in order to impact healthcare, it's really going to take a collaborative impact and get out of silos. So talk to me about, because that's the one thing that has impressed me the most about South Carolina. While we've been doing it in other states, a few weeks ago, I aired on one of my episodes an interview that I did with Butch Oberhoff, who is the president for the Texas EMS Ambulance Alliance. But South Carolina has done some very, very unique things relative to what you're doing. So I want you to tell a little bit about that, because it's the collaboration that is the only way that we're going to impact healthcare is to do more collaboration.
Could not agree more. I think that the real strength of South Carolina is the essential partnerships. And great that you mentioned Butch, because Butch is one of the mentors that's helped us along. Obviously, TIMS has been around a lot longer than we have, but we really started with the unmet needs idea and what can we do locally to try to make these partnerships. You hear all the time that if you're not at the table, you're on the menu. Our experience in South Carolina, and I would dare say probably could be replicated anywhere, is that there's not a malicious intent to exclude EMS from tables and meetings. It's just that EMS isn't present because we don't know how to be there. So we set out and we originally had a public association, a private association, air ambulance, educators, public information and peer, and there were so many fragmented groups. Around 2018, we really worked hard and were able to move all of them together under the singular umbrella of the South Carolina EMS Association, which we think is very special. We represent all things EMS in South Carolina, and there's so much power in that when we go to the General Assembly. Most recently, we passed provider assessment legislation, and we also at the same time put together an ASPP program that allowed for the governmentals to also have Medicaid funding. What was really unique is when we went and lobbied for this, we had folks from the other side of the organizations lobbying for each other. Public folks were lobbying on behalf of the non-governmentals and vice versa. We also work really strong collaboration-wise with the Hospital Association, Public Health Care Association, Rural Health Care, all of the folks that are at the table. When we actually look at what the strength is with that, there's so much overlap. EMS is the epicenter of patient navigation for all of healthcare. We're doing so many things in these other spaces, and folks are actually elated when they realize what we can do to be synergistic in terms of our approach of how we deliver these, most recently, community-based systems of care.
Well, and I think it's important because you said a lot in in that little 2-minute clip. So I'm going to expound upon that a little bit. Some of the questions I'm going to redirect on, because we're going to get to the One Big Beautiful Bill.
Yes, sir.
Because that did impact some of these provider assessments that you talked about, state-directed payment concepts as well. And I'll probably end with a little bit about that. But let me unpack back to 2018. When you started as an association, you guys were having workforce shortage issues once COVID hit, which really impacted a lot. It really brought to the forefront our issues with workforce. Now, whether you talk to someone that we have adequate workforce, maybe they're pigeonholed into the wrong positions. I'm not going to debate that here. I'll let you kind of opine on that or what have you. But it did bring to the surface pretty quickly that there was a workforce issue. And you did some very creative things. I talked to Butch in Texas. They did some creative things, but you've done some very notable things that have been some of the first in the industry to be doing, or that I'm aware of. And so can you talk a little bit about that? Because what I like about what we're doing is we're getting people to start thinking outside the box, start thinking things creatively outside of just funding. So talk to me a little bit about that.
Absolutely. So glad you asked that. Really the catalyst that created our growth. We sat down with all of these other organizations, the private association, air ambulance, and the thing we had in common was everyone had the workforce issue. So we made a very great partnership with the South Carolina Office of Healthcare Workforce through our AHEC organization in South Carolina and created 2 studies respectively. The first published paper that we did was the EMS workforce pipeline, and the second one was about our education systems, because you can't have a conversation about workforce without the pipeline for education as well. Those 2 documents actually led to the South Carolina EMS Sustainability Plan. Our legislator funded our organization over $1 million for us to develop workforce development pathways and programs. We also have congressionally...
So tell me how you did that. Not to interrupt you. Tell me how you got South Carolina to fund $1 million in the state budget when most are cutting their state budgets. Tell me how you did that.
We really just took a very simplistic approach. We went to the folks that were making these decisions, and we didn't just bring a problem to them. We brought them a problem, and we brought them a solution. So when we went to make
Important to note if you're listening.
No doubt. Data is great, and you can get funding, but you have to have a plan. We didn't go in and lay at the feet of the General Assembly that, hey, EMS workforce is bad. Well, how bad? Really bad. Can you do any better? Well, no. We had the actual data. Startling. The average age of a paramedic was over 42 years old in South Carolina in 2018. And again, all of this, as you pointed out, was prior to the pandemic. So we knew that we had, 30+% vacancy in our EMS classes, all of our EMT, advanced EMT, and paramedic courses. There was no real way to address how you get folks into the pipeline. So our plan really focuses on 3 core pillars: awareness of the EMS careers, access to the education, and then controlling costs so that we can be competitive. In rural South Carolina, if you take someone who's underskilled, looking to upskill, maybe enter an EMS or a healthcare pipeline, if their options locally are I have to pay a few $1,000s to go to Class A or I can take Class B for free, that could be a decision maker. Even more so that what we found recently in terms of what we're doing with the expansion of our education, and I definitely want to talk about that in a second, access is such a big thing because if you have somebody that's interested in moving up in the career path line, and so they're thinking about what they're going to do, but the closest education opportunity is an hour-and-a-half drive. It's on Tuesday and Thursday night. Now you've created barriers with healthcare or childcare. You've created barriers with transportation. All of those things really are the wraparound services that we felt were limiting factors. So When we went to the General Assembly, we said that if you can fund us for this, we're going to do a statewide recruitment as an initiative, which is still ongoing right now. We recruit for all 236 EMS agencies in South Carolina. We've seen over 4,000 consultations that have come through our platform alone. We've found scholarship funds through the Office of Rural Health, through our scholarship foundation, lots of other pathways. We worked with the General Assembly and our governor to make education free at our technical colleges. So we really just tried to look at this from what are the barriers and how do we tear those down.
And is the legislator still funding your ongoing initiative now, or has that ceased?
Those funds are still in play for another 2.5 years.
Okay.
So we are still working with those funds. And as I mentioned, we have congressionally directed spending from Senator Lindsey Graham. He has been a fantastic supporter of EMS as well. So we have 1.6 from that has created our safety net education program.
So you had a congressional spend through Senator Lindsey Graham that directed $1.6 million dedicated funds into South Carolina and the education program.
Specifically to our organization as a partnership between us and our foundation. So we created what we call the Safety Net program, and we're really proud of this because of the fact that across our state, we have a lot of, I guess, what you would call education deserts, places that just really don't have infrastructure. Those are the places that are also hurting for EMS workforce because it's difficult for these small services to recruit and try to attract people from the bigger metropolitan areas. Through this asynchronous program that our organization designed, we are now able to offer one-off classes, small cohorts, local regionalized classes in partnership with the host organization so that we can deliver education in every corner, every spot in our state, and even better, we can do it cost neutral. So our turnkey solution is that our marketing team runs all of the ads, we run all of the social media campaigns, we agnostically recruit into the profession, and we let the folks pick where they'd like to work based on their own geography. If they have the opportunity to do a class on their own, then we support them that way. If they don't, then we can actually go turnkey from finding somebody that's interested in the career all the way through the credentialing process and the placement.
So here's what I think is important for people to know. And I'm sitting here listening to you, and there could be people that are listening right now that are saying, you know, Henry, that sounds great. You have an infrastructure to help you to get that, but you didn't start that way.
No, sir.
So when this started in 2018, give a little, because what do they say? It's the Chinese proverb that says, when's the best time to plant a tree? It was yesterday.
Yes,
or
right.
It's today. And so my standpoint is talk about that, because many people look at it and say, this has taken some time to get you to where you are now, but you need to start. And so explain that, because I know what your story is, but most people don't. So tell me, I know you talked about starting in 2018, but you started with literally hardly nothing. So explain that really quickly if you can.
Yes, sir. We were an incredibly fledgling organization. Less than 30 members. We really didn't have a lot of infrastructure, no paid staff of any kind. We had a contract lobbyist that worked with us and did a great job, but really no direction there. What we really determined, though, is as we were talking about making these essential partnerships, we have a great relationship with our state EMS office, but they're a regulatory body. They wake up with a much different mission every day than I do. And so we recognize that it's difficult for volunteer leadership that's involved in the association to try to take off of work and try to do all of the things that you need to do to be in the rooms and to have those relationships. So we started trying to think of ways that we could build towards that. Again, from all volunteer, by 2019, we had onboarded some admin staff, just kind of contract 1099 stuff to help us. The pandemic really exacerbated everything for us, and that is when we really recognized that everyone is fighting to try to keep their service afloat. They're trying to do so much that the association largely went dormant for the majority of 2020. When we came back out of the other side of that, that's when we realized, hey, we've got this data, we've got this plan, let's go to the General Assembly, let's get some funding. I think that it's critical to note that if anyone is in a smaller association or looking to grow, everything that we're discussing today is completely transparent. We're happy to work with anyone and share. But if you can get that narrative, if you take the data, you take an approach and you find a solution, ours happen to be just geared towards the workforce development. That's the catalyst that gave us the opportunity to onboard myself and some others. And now today we're over 10 employees as a state association and
I
still
think
growing.
that's important to note. is find the one message that you can unify. And you guys found the message as workforce. Many times what I see is we try to do way too many things at one time.
So
We have
true.
way too many voices. And so what happens is you get nothing done because you're trying to be good at 5 different things. We need a Medicaid increase. We need to cut cost here. We need to do this. And so what happens is you've got too many messages. And so nothing happens. You guys unified on one. I want to make that point because that's that's why I'm asking you that question. I'm going to switch subjects really here because I know we're getting through this and people are talking in the workforce. If you've learned anything so far, find a unified message, especially if you're starting out, and start working on that together. Volunteer. There is funding available to you. You're one of examples. I'm hearing it across that many more are starting to do stuff, but it takes time. Slow and steady wins this race. If you're looking for it to happen very quickly, you're setting your expectation. You're setting yourself up to fail, but it will take some time. But utilize resources like you, Henry. You've been gracious to do that, and I know that's a part of your generous heart is to help anyone that picks up the phone and calls you. You'll do that. Let's talk through some of the stuff, and I want to pivot here because you did some stuff in rural America. You brought that up. You've
Yes.
got a history. There's a reason why you're passionate about rural. It's close to home. It lives with you every day. And so I want to talk about that because you partnered with a company to do some stuff around. We're talking about mobile health care. We're talking about community paramedics. We're talking a lot. You guys did something in your state. Other states have mimicked and done something similar, but you've been very unique in this in the partnership that you did and developed. Can you talk a little bit about that?
Absolutely. And, to touch on the things you were saying earlier, really these relationships start with trying to make sure that you have the narrative and that you're able to articulate what EMS truly is. That was really the sounding board that we've enjoyed so much because as we started looking at community-based systems of care and changing the narrative, let's move away from talking about EMS as a transport resource. Let's talk about EMS as part of the healthcare continuum. We talked with Blue Cross Blue Shield in South Carolina. We talked with some of our partners at the Hospital Association. And we recognize that we've had so many CP and MIH programs that started up through philanthropic funding, grants, and things like that with no real clear plan for sustainability. With that in mind, something that's very near and dear to my heart, I live in a rural part of South Carolina, and my wife actually runs the rural health clinic that services that area. So in partnership with one of our private EMS systems, First Priority in South Carolina, we've now embedded a community paramedic through grant funding for the Center of Rural and Primary Health Care into this rural health clinic. What's fascinating is that all of the things that they measured, gaps in care, HEDIS measures, folks that are lost to care, this community paramedic is able to go find these folks and make meaningful change in their lives all across 2 counties. And just in the year and a half that we've done this program, we're looking at hundreds of people. The results have been so well founded that now we've gotten sustainable funding that's come back through Center for Rural and Primary Health Care, expanded the grant. But we're also able to use this as kind of like an opportunity to test drive a Rosetta Stone, to translate what the EMS care is compared to what the rest of healthcare speaks. And I think that's something that's really unique because we've always talked about, do we find modifiers for HCPCS codes or what do we do? But social determinants of health screenings is something that's reimbursable, and paramedics have been doing that since we began. We do so many
We didn't
things.
even realize we were doing it, but we've been doing it.
We do. And, as we start looking through this has been a great opportunity for us to use the Fairfield Medical Associates example to try to crosswalk what CPT codes correlate to what we're actually doing in EMS, how some of those innovate with some of the opportunities that exist for community health workers and the like. So we've found funding streams that now can reimburse for this. And even better, again, going back to our overarching message of partnerships, here we have a privately owned rural health clinic that services the lives of, 12,000 people. And we've got a non-governmental EMS agency that took the initiative to move into the CPMIH space. We brought them all together in collaboration with a state funder and a nonprofit association. So 4 stakeholders all working for the good of the patients. And no one is really trying to take credit. It's such a selfless thing because it just makes sense. And I'd be remiss if I didn't say this is one of many CP programs. We have over a dozen in the state, but there's no one way to do CP in community-based systems of care. And we talked to the General Assembly. One soundbite I have to throw in. There's such an appetite for this because when they talk to us about, well, what is the future of EMS? One thing that we can say for certain is that it's not faster ambulances. That's not what's going to fix our problems.
And that's correct. If you've not heard anything, and that you hear that general sentiment, we are mobile healthcare. We're not just a ride, but we have been incentivized to be a ride specifically because that's how the payment methodology. And there was a lot of discussion that's been happening around disconnecting payment from the actual transportation and looking at EMS holistically. But in that continuum of care, you guys are expanding outside of it, but this is the one thing that with EMS that we actually own and control is the unplanned, unscheduled part of the healthcare continuum. There's nobody that does it better than EMS. And that is generally because of we understand the logistics of things. We understand the transportation. So the transport side of it has taught us something as an industry. But we shouldn't stay stuck in the transport side because we have the ability to do so much more, which is things that you guys are demonstrating in South Carolina right now. First priority in that collaboration with the rural health clinic, understanding the different codes to bill that the rural health clinic is billing for, but you found sustainability through grants and ongoing sustainability. Because the first thing that I hear is like, well, grants aren't sustainable, Asbel. They can be if you create the collaborations correctly.
And then furthermore, take the outcome data and begin socializing the conversation. We have some champions at the General Assembly at our state Medicaid office. These concepts that we're talking about, we have been socializing these for over 5 years. So now that we're actually creating this outcome data, we're showing that this works. We have pathways now that we are looking at some state plan amendments. We're at the table concerning some of the things that we're looking at with changing this methodology because, again, if you approach this from the lens of the patient and what makes sense for the patient, it's not always all about the economics. If that's the way that you're approaching the conversation, you might be putting off some folks. But if you come to them with the ideology that, we're responsible in EMS for 1.6 million calls per year in my state alone, and you're talking about a state of 5 million people. So what can we do as we impact those people, particularly the, low acuity, high frequency utilizers? That patient population is somebody that's not benefiting from what we're doing. To your exact point, not only is it a wrongful incentive that we transport all of these folks to the emergency department, we've created something that now is a Medicaid nursing home in our emergency departments almost, because this isn't a place that these people need to be either. So really, I think there's a huge appetite for it, but the narrative and how you control that messaging and the way that you approach it matters just as much as what you're trying to accomplish.
So this is a good segue into the final piece that I want to talk about, and this is around the One Big Beautiful Bill.
Yes, sir.
And there are two main components that we talked, and I want to stay while we're on this rural piece, this Rural Stabilization Fund. And there has been $50 billion appropriated, whether you feel about that or not. Some people are saying estimates could be that it's only a third of what has been currently funding the rural system. We shall see if there's any waste in that, any what I call pork in that type of component. But what we do know is that CMS is going to be looking at innovation models that states put together. And I know there's been some conversations happening across different states, but in my opinion, knowing what I know and where I sit in understanding the healthcare finance land, you guys have been doing some very yeoman's work. And outcome data is very important. Most people will know that I have been on this kick that says it is going to be the data companies with clinical outcomes that are going to lead innovation in healthcare, number one, but specifically in EMS. And so there's been some stuff, if you are open to disclosing some of it you may not be able to talk about, but if you can talk a little bit about what you're doing in South Carolina, because there has been a very concerted effort that you have done by building these collaborations that has really allowed EMS to really take a leading role in possibly how delivery in rural healthcare can augment because of the One Big Beautiful Bill.
Yeah, as you look at the developmental models and the innovation that are in these opportunities, I think out of the 10 different elements that they wanted you to satisfy 3, arguably EMS checks the box for 7 of the 10 easily. And so, again, going back to some of the conversations we've had, we didn't worry when we heard about this thing coming out and EMS may or may not be included. Our state Medicaid office said EMS will be at the table. We will be one of the key stakeholders. So we're really proud to say that we've put together a working coalition with the South Carolina Office of Rural Health, the South Carolina Hospital Association, our organization, and the South Carolina Primary Healthcare Association. What we're looking at is kind of just exactly to your point. What I can share with you is that if we could flip from being compensated for transport or reimbursed for transport to having compensation for delivering care, that would fix so many problems. What we know is that in South Carolina, arguably about 8% of our call volume are true emergencies that are time sensitive, and over 60% of our call volume really doesn't require an emergency department level of care. We're in the developmental phases of a process or a program now that we think is going to be really novel, and in short, it's going to compensate EMS for delivery of care by the mechanism that the paramedic and local medical control sees as appropriate. So that would be a pilot specific to Medicaid, but we also have a rate setting survey that we're funding right now that's going to address some things with commercial insurance, and we're applying the same methodology to that as well. So we're thinking that we have an easy opportunity to crosswalk this into commercial insurance, because you hear so many times we're budget dust, we're a rounding error in the overall spend. While we recognize that cost avoidance does not revenue make, it is undeniable that if EMS more appropriately uses the resources that we already have, we're embedded in the communities, we are trusted in the communities, we know what the other resources are. All we're looking to do is empower the EMS systems to do what they know is right for the patient and compensate them for that.
Yeah, and if you're listening to this right now, I'm going to direct you to a podcast that I just did with Dr. Lisa Graybear. She's a healthcare economist that also worked for CMS, that worked for Ways and Means, where we discussed how EMS could impact the impact of the cost of care downstream. And so she actually brought up some great information. We're actually going to do another episode, and this is to your point, Henry, which is wonderful. So if you've not listened to that podcast, strongly suggesting that you go back and listen to it, because it's from a whole different perspective. It has nothing to do with EMS, but from a healthcare economist perspective who has skilled and understands the impact. And specifically, we talked about the Rural Stabilization Fund.
No doubt.
And some of the statements that she made relative to that. We're going to end in with the last question that I want to really talk to you about, with some of the provisions around, you brought this up briefly at the very beginning of this podcast, around how the state of South Carolina, around Medicaid financing, there's some things that you had been working on in EMS as an initiative over the last year to help not only governmental EMS as well as private EMS augment, because we have a huge uncompensated care portion of the community that we serve. When you call 911 or you need health care, we respond. We're not asking you, oh, you don't have insurance. And I always say this analogy, I'm so sorry, you're just going to have a heart attack. And if you die, you die. Because, of course, that's not going to be, because we believe in humanity, compassionate care. What is the best thing to do for the patient? It doesn't matter your status. It doesn't matter where you were born. It doesn't matter anything. You call 911, we're responding. And so these Medicaid financing programs were critical to EMS through the process. And the One Big Beautiful Bill did put some caveats in place that that is totally re-engineering what these processes are. Explain, as the bill was going through the process, and there was a lot of concern at first with South Carolina. I know you and I were on the phone. We were trying to figure
Yes.
things out because of it with the approval. So talk us a little bit about that, because one of your senators was very instrumental, and most people may not know that. And I'd like for you to kind of talk through that piece of it, because we need to give kudos to where kudos is given. And one of your senators really came through for some. Now, it didn't fix everything for everyone, but it did fix some states that were going to be impacted by some of the provisions that were being debated.
No doubt. And I certainly appreciate this question. We've been working for quite some time to move into the provider assessment, and so we worked with our General Assembly and our champions in state. Finally got this thing done right under the radar, and then here comes the big beautiful bill with implementation dates and changes. And so the language that came out of the House was, okay, it didn't really do much for us, but when it moved over to the Senate, the first draft that the Senate dropped, when it had the implementation date of programs originating in June or after, ours was signed into law in May. So we were right there on the cusp, couldn't get that done. picked up the phone and called our friends in D.C., and Senator Tim Scott at Senate Finance really came through for us in a huge way. He's been a huge supporter of EMS in our state in general, but through a series of conversations, he was able to make sure that the changes protected South Carolina EMS. He's furthermore reached out since then and really made sure that we were included in the Rural Transformation Fund, made sure that our state is making EMS a component of how we look at the next evolution of how healthcare is delivered. Because again, you just can't have these bigger conversations about healthcare without recognizing the role of EMS. So the senator called multiple times actually and had staff working with us directly and kept us informed, but we're happy to say that that protected a little over $16 million in additional Medicaid revenue for EMS systems across South Carolina that in a lot of these cases are delivering rural 911 healthcare, and they are the critical access point for these healthcare deserts that we have in our state that don't have hospitals. So,
well, and I think too that the one thing that we talk about, just like having a rural stabilization fund, we've talked about having kind of an EMS stabilization fund.
yes, sir.
Or an understanding of if somebody calls 911, we respond, we take care of it regardless of your ability to pay. And many times things are either paid through local taxes or millages, or could be out of the state funds, or could be part of a payer, whether it's Medicaid, Medicare, depends on what happens there. And so it's just a uniqueness of it when it comes to it. And we're not the only healthcare sector that has it. Emergency physicians have that ERs and rooms like that, but they have access to other funding that we may not necessarily have access to that help pay for some of that. So it was really critical, number one, for them to hear. Did we get everything that we want? There were some advocates, but the point that I want people to hear today as we close this out, and then I'm going to ask you one last question that I ask every podcaster, or every time I do a podcast regarding when we talk about healthcare. But the one thing I want people to understand is the power of relationships.
Absolutely.
And they can't just be local. They need to be at the state level as well. People need to understand not just your challenges with workforce. That's how you got started. But you expanded pretty quickly saying sustainability. You started looking at everything around EMS sustainability, but you didn't also lock in and say, we might have to do things differently to EMS.
Right.
We might have to go in there and think outside the box, but also understanding the power of your congressmen and women, and as well as your senators, have on the national that impact what goes on in the state of South Carolina. And I think that was key because you were able to pick up the phone and literally you were able to bring that to the fore that they hadn't even thought about was going to be an impact. They didn't realize that the May 1st deadline was going to be a problem for the state plan amendment that was approved after that, and that basically it would almost make it null and void from that particular perspective. And it wasn't until you had those conversations, and then that's where Senator Scott could get involved in assisting with that as well. So I think that's what I want people to really, really hear. So Henry, I'm going to ask one last question as we end here, that if you could look in your crystal ball, and if there was one thing that, and I'm talking generally in healthcare, I know our focus right now is EMS because that's really where your background is. But if there is one thing that the EMS industry should pay attention to, I would say in the next 6 months to a year, that if you could just wave your wand and make it happen, what would that be?
That is a huge question because there's so many things that come to mind.
You got to pick one.
So I think that redefining the narrative of EMS is so critical. And I think that what we have to recognize, I often use the Henry Ford quote that if he would have asked his customers what they wanted, they would have said a faster horse because they didn't understand the car. I think that we've really got to embrace and lean into the idea that we cannot be a transport industry. I think that you're going to have to see some concessions in some of these partnerships and understand that as we look at how we integrate into both vertical and lateral healthcare systems, we as an industry will have to make concessions no different than the other parts of healthcare that we're encroaching upon. But I kind of see a future, if I could wave my wand and make anything happen, I'd like to see a future where EMS clinicians are recognized as top-tier credentialed at paramedic level and that we have integrations into all of these other systems to include primary care, to include hospitals. There's such a fear and an apprehension of, we're going to be this pipeline that only is a stepping stone into other parts of healthcare. We hear that so often. We could talk for hours about our experiences in our education platform and what we've seen. But truth be told, career ladder is somewhat lacking in EMS. And so being able to have paramedics that are used in atypical settings and recognized as paramedics only serves to strengthen our industry, provided that we keep the infrastructure and the pipeline there to where we're not doing so at the peril of our own workforce. But if you look at redirecting and rethinking what we do in EMS and how we utilize paramedics, I'm happy to say that largely across South Carolina, we are adequately staffed. We have some places that are fully staffed with waiting lists. What we've seen is that these partnerships and changing the culture and giving folks opportunities to work collaboratively and be recognized as healthcare providers really makes a big difference in our retention.
So what I'm hearing from Henry, and I'm going to sum it up this way, you can either protect and preserve, or you can adapt and innovate. And what Henry is saying right now is the industry, if you had to look at it, we have to adapt and innovate. The healthcare industry in general has to adapt and innovate, and this administration, as well as this Congress, is putting downward pressure on rates because that generally will move you into adaptive mode pretty quickly because the innovation comes out. So there's opportunity. There's opportunity in EMS. And so, Henry, I want to say thank you for joining me today on the Leadership Lab. And it's always fun to be in studio with one of my fellow South Carolinians. So thank you guys for joining us today.
Thank you.